Greetings, overcomers, and welcome back to Connect Over Coffee. Today we have Dr. Ronnie Drapkin with us. Dr. Ronnie Drapkin from Penn Medicine is one of the top ovarian cancer researchers in the country, and his lab focuses on developing a comprehensive understanding of the genetic, molecular, and physiological factors that drive the development of gynecologic cancers. Dr. Drapkin is also on our advisory board and has been a superlative help to us in guiding our course forward. So with that, thank you, Dr. Drapkin, for joining us today. It's an honor.
Thank you for having me. I'm really glad to be able to do it.
And you have done so much work and I have so many questions. So we'll start with the first one. So based on your extensive work, tell us about the genetic, molecular, as well as physiological factors that may drive the development of ovarian cancer.
Sure. I think a lot of people are familiar with the fact that genetic factors, and I'll refer to them as sort of hereditary as well, play a big role in this disease. Family history is probably one of the most significant predictors of this cancer. And so the cloning of the BRCA genes in the mid-90s really sort of opened up the opportunity for not just understanding the disease better, but thinking about genetic counseling and testing, which we'll touch on, I'm sure, was a big factor. So the genetic predisposition piece of it is really important. The molecular piece of it, which we've learned over the last 20 or so years, really says that this disease is a disease that manifests as defects in the ability to repair DNA damage. So this is a kind of a classical disease of DNA damage dysfunction. Some people refer to homologous recombination dysfunction, which is just a sort of particular type of DNA repair. But it really, that's what characterizes this malignancy. And then the physiological parts to this are really grounded in a lot of epidemiologic data, old epidemiologic data, in fact, that has been kind of reaffirmed over the years, which is that this concept of incessant ovulation, right? Ovulation that is not interrupted either with oral contraceptives or childbirth or breastfeeding, which really kind of pause ovulation. Incessant ovulation is a risk factor for ovarian cancer, whereas things that block ovulation, like the things I mentioned, are associated with a decreased risk. So there's sort of the genetic piece, the defects in the cancer itself that we understand, and then the physiological pieces that we think contribute to the development of this disease.
And we talked about this a couple of years ago, but tell us about the reclassification of ovarian cancer and the role of the fallopian tubes as the likely cell of origin for a majority of high-grade serous ovarian cancers. And has since our conversation, what has changed, if anything?
Yeah, sure. So I think now, it's 2020, so we're going on, about 25 years since the BRCA genes were cloned, right, in the mid-90s. And that was really the beginning of the whole story about how we changed our views of this disease. So cloning the genes in the mid-90s, by the end of that decade, we were offering patients prophylactic surgery, which really was only proven to be effective, years later. But the idea was take out the tissue at risk and we may be able to save lives, right? And that's really been a major factor for risk reduction in this particular disease, at least from the hereditary perspective. And as early as 2000, 2001, when people, especially pathologists like myself, were examining those tissues that were taken out, in particular the ovary and the fallopian tube, a lot of effort and emphasis was placed on the ovary because this was an ovarian cancer. And we would look at every single piece of the ovary under the microscope, looking for those early cancers that might give us a clue as to what's the cell of origin, how does it actually start, what can we think about with regards to early detection or prevention. But some really astute scientists and pathologists in the Netherlands started reporting weird-looking cells in the few sort of limited sections of the fallopian tube that people were looking at the time, 2000, 2001. And that really got us, I was I guess a postdoc at that time, and I was still working with Chris Crum at the Brigham and David Livingston's lab studying the BRCA genes. And Chris decided that we really had to take a better look at the fallopian tubes, because maybe we were missing something, since everyone was reporting these weird things in the tube, but we were looking for ovarian cancer. And so he developed what we call the CFIM protocol, which is a protocol to section and extensively examine the fimbriated end of the fallopian tube, which is the very distal end. If my arm is the fallopian tube, the finger-like projections of the tube are called the fimbria. And they are sort of surrounding the ovary itself to make sure that that egg that gets released every month goes into the tube. And really, when we systematically looked at the entire tube, we realized that all the precursor lesions that people had been looking for in the ovary were in the very distal end, the finger-like projections of the fallopian tube. And that was really kind of the beginning of this sort of paradigm shift in the field, where we started to realize that, wow, these cancers are probably coming from the tube, not the ovary per se. And the ovary may actually be a secondary site or metastasis from the original. And since then, a lot of people have implemented the CFIM protocol, not just in the United States, but across the world, and have reported very similar findings. And I think in general, over the last 10, 15 years, there's been this acceptance that a majority of the most common kind of ovarian cancer, what we call the high-grade serous carcinoma, probably arises from the fallopian tube. In the last handful of years, have been sort of genetic studies that kind of really prove that concept.
And why is genetic testing important? And it seems that the genetic testing rates for ovarian cancer still remain low. And how do you think we can address and overcome this challenge?
Yeah, so to answer the first part in terms of why it's important, at the beginning it used to be important because how it affects our ability to not just guide the patient, but also their family, right? So if you harbor the gene, it could mean that you got it from your mom. It could mean that your aunts might have it. It could mean that your sisters might have it or your daughters might have it. I think it's important also to emphasize that that was really how we thought about it, but we used to forget about the dads and the men who could also carry this gene and pass it down to their daughters. And that was really, really important. But with the recent development of PARP inhibitors, which is a very sort of targeted therapeutic for tumors that have defects in the BRCA genes, now it's not just important to get tested because it informs counseling. It's important to get tested because it might actually be a therapeutic option for you as a patient, right? And that's something that has completely changed the landscape with regards to how we think about the treatment of this disease in just, 5 years or so. So I think that that's been, a really important part. In terms of why testing is low, you probably recall that not more than a few years ago, the recommendation was made that any woman who has ovarian cancer should get BRCA testing because the prevalence of these mutations was much higher than we used to estimate. We used to think about 5, maybe 10%. It's probably closer to 20, 25%, and that's a significant increase. And so the recommendation has been for any woman who has ovarian cancer to have testing. Why is it low? I think part of it is to some degree, lack of education. I think we have to do a better job of that. Not only in the tertiary care centers where you have sort of the thought leaders in this, but even in the community setting. And through foundations like Overcome and others, where we can really get the word out about why it's so important to get this testing done. Again, the impact is not just on the patient, it's on the family, and it's on the opportunity for new therapies that are out there and continue to emerge.
And this is what we stress upon when we speak to patients through our Overcare program, to your point, that are, probably being treated at a community hospital, and they've either been not spoken about genetic testing, or the patients themselves are not interested because they don't fully understand that genetic testing also at this point in time, it's not just your family members, but it is also you, that it will directly impact your treatment path forward. So each time we talk to patients, we make sure that we stress upon these factors as well. So thank you for bringing that up. And there is still no effective screening for ovarian cancer after all these years. And why do you think that is? And tell us about any promising research that's on the horizon for ovarian cancer, because good thing is a lot of things have happened in the last 5 to 7 years, that has taken the ovarian cancer progress like leaps and bounds. So tell us what is on the horizon that's promising.
Yeah, well, I think you sort of hit it on the head. I mean, people, when I first got into this, I got into it with the idea of early detection, right? This is a disease that's diagnosed 70, 80% of the time once it's already spread beyond the confines of the ovary or the fallopian tube. And so you're talking about stage 3 disease and aggressive surgery and chemo and things like that. So why is it that we can't detect it early? I think part of it was because we did think that a lot of this was coming from the ovary, and we were looking for things that might tell us that. I think with the understanding that the tube is the primary site of origin, lots of things have been changing in terms of our thought process. If you just imagine the scope was focused on the ovary, and now we just shift a little bit over to the tube. So I'll tell you one story I think is, or maybe two, that I think are really exciting. So a study that Karen Liu out of MD Anderson started called the WISP study, which is Women Choosing Surgical Prevention, is looking at this idea that if in fact these tumors come from the fallopian tube, might we be able to provide women the risk reduction that we've been doing for years, right? But not take out the ovary at the same time, right? And by not taking out the ovary at the same time, we spare those women what we call the surgical menopause. And if you think about it, for someone who's a BRCA1 mutation carrier, the recommendation is that they have prophylactic surgery by age 35, which is many years prior to their natural menopause. And by taking out the ovary at that age, they are susceptible to all the morbidity associated with menopause, the heart disease, the bone, disease, etc. And
there's
so
childbirth considerations as well, right?
Absolutely. I mean, the idea is, that's the recommended date, and then you also have to consider, well, are you done with childbirth? And so there's a lot there that goes on at a very young age. And the thought is, well, maybe if we just take out the tubes, we could spare women those morbidities, right? And preserve their ability to have kids, albeit with in vitro fertilization, but they can still have their eggs harvested and so on. And that's been one thought, and the WISP study was really designed to give women an option. Women who didn't want to have that surgery because they didn't want to experience a surgical menopause at that young age were offered the ability to say, we'll just take out your fallopian tubes first and then come back and take out your ovaries. And the WISP study itself is a relatively small study. It isn't really powered to sort of give us the ultimate answer, which is taking out the tubes as effective in terms of risk reduction as taking out both the tube and ovary. But it is telling us that it's actually a safe procedure, right? And as a result of that, the WISP-2 study and the TUBA-2 study, which is a European study very similar to this, are underway and being developed, looking at now thousands of patients to ultimately answer that question. Is taking out the tube only equivalent to taking out both tubes and ovary for risk reduction without putting women into menopause, right? So that's, really interesting, and it's exciting that that's kind of moving forward, and we already have data on some of that. The other is a company called Envision Medical that was out of San Francisco. And this was a group of bioengineers who wanted to really think about this problem and figure out ways that you could actually develop some kind of tool to do early detection for ovarian cancer. And so they, being very smart engineers, didn't want to reinvent the wheel. They said, look, there's a procedure called the hysteroscopy, which it gives the physician an ability to look inside the uterus. And oftentimes this is an outpatient procedure. And we use it to look for things that could explain infertility, for things that could explain abnormal bleeding, and to see if we could identify something inside the uterine cavity. What they said is, let's take that concept, the hysteroscope, and basically add another component to it that will enable us to deploy a balloon catheter into the fallopian tube, all the way out to the fimbriated end. And the surface of that catheter sort of has a texture that if you sort of rotate the balloon, you sample all the cells in the fallopian tube, and then you retract the balloon, and now you have essentially a pap smear of the fallopian tube. Okay, and they've done a number of studies now. We're completing a phase 2 study at Penn with a number of other organizations and institutions looking at deploying this in women who have abdominal masses that are going to get surgery, so that we can compare what comes out from the surgery versus what we saw in the cytology, as well as women who are at high risk, right? To start asking the question, can we use this as a way to assess the fallopian tube in women who have the BRCA mutations but are not ready yet to have surgery, right? And so this is like the first time that there's been an ability to actually access the fallopian tube and sample those cells on the heels of the understanding that this is really where most of these tumors begin. So these are things that are already in trials. And Boston Scientific actually bought out Envision Medical within the last year or so to further develop this. So I think those sort of approaches are really changing the way we think about early detection and the way we think about prevention, because we now understand that many of these cancers begin in the fallopian tube. So I think that's very exciting.
It is very exciting and it's a game changing, I think it is game changing because early detection is so important for ovarian cancer. It is just, in my lifetime, I want to see us get there where we actually have that, mechanism in place where we are able to detect patients and do the screening, because even to this day, when we go to doctors for our well woman visits, right? No one talks about ovarian cancer. And, even though organizations like Overcome or the others are trying to change that, but there still isn't any prescribed way of screening for ovarian cancer, and no one even talks about it. So that's great to know that there's so many things on the horizon as far as the research. So thank you for sharing that.
Sure.
I have to ask you on this COVID-19 question, right? With all this going on, what guidance would you give to our overcomers as we go through this crisis?
Yeah, I think it's really important. It's very easy, let's say, to sort of feel overwhelmed with everything that's going on. And what I think we try to keep emphasizing is that you want to first focus on the things that you can control, right? Because the things you can control give you power, right? Give you energy. And I think a lot of it is about sleeping well, eating well, exercising well, trying to maintain some degree of social interaction, albeit virtual, right? Or going for walks with family members. All those things are really important to keep us grounded and keep us healthy, in addition to practicing the social distancing that I think we have to. And it's really important for overcomers and other cancer patients to sort of heed that recommendation that's out there, because you are more at risk. Your bodies, if you've received chemotherapy or other treatments over the years, leave you with an immune system that isn't quite where you'd want it to be. And so you want to sort of really focus on that. I was just reading an article in the New York Times, a friend of ours who has cancer, and her husband got sick, and he quarantined himself, basically barricaded himself in his bedroom for 18 days because he knew that he couldn't put her at risk, right? So she writes a story to him, thanking him for this. It's a beautiful story.
That's so sweet.
So you could share it, because I think it's a really nice story, but it really does emphasize the unique place of cancer patients and their need to sort of really be vigilant about these things. But like I said, I think there's a lot you can do to empower yourself, and it's a lot of things that we can control as individuals, right? Very important to eat well. I think it's important to get regular exercise daily. As the weather starts to get better, go outside, get fresh air, right? At least
it's 90 degrees in Houston right now, so almost 90 degrees. So
we had I think 60 degrees in Philly, and then last night it dropped to below 30 out of nowhere. It was really weird. So I'm hoping we're going to get into sort of more like typical spring-like weather, because I think everyone is craving to kind of get out of the house a bit. But I think it's important, and it's too easy to fall into the trap of just kind of maybe getting depressed and feeling bored. But I think if you sort of outline almost for yourself, eating, exercising, interacting, sleeping well, you can create a daily plan for yourself that is a healthy one, keeps you a little saner.
And that's a great advice. Thank you, Dr. Draken. My last question, we know that ovarian cancer is a silent disease, but at Overcome, as you know, we encourage everyone to be vocal about ovarian cancer and to keep talking about it. So what is your message to our audience regarding ovarian cancer awareness, and what positive message would you share for our overcomers?
Yeah. I'd kind of give you a historical perspective, because for me, I still find it incredible what's happened. In 2000, so 20 years ago, I was a wet behind the ear postdoc, just starting out in the laboratory of David Livingston. And David Livingston at the Dana-Farber really gets credited with the understanding that we've developed over the years of how the BRCA genes work, right? Which is that they are involved in maintaining the integrity of our DNA, right? They are involved in DNA repair. And I remember clearly having a conversation with him in 2000, asking him, well, the BRCA genes are tumor suppressors against breast and ovarian cancer, and yet everybody in the lab works on breast cancer. How come nobody works on ovarian cancer? And he said, look, the reality is we don't know enough about it. We don't know really where it starts. We have no early detection. there isn't enough money in it. And, you know, I kind of asked him, well, would it be okay if I sort of try to dabble in some things I thought was interesting? He was like, absolutely sure. He was always very generous in that. But he was right, because back in 2000, we didn't have these organizations, right? There was the Concert for the Cure of Breast Cancer, the Race for the Cure of Breast Cancer, all these other things that were going on for breast cancer, very little in ovarian cancer. And I now look over the last 20 years, and I've never seen as many researchers involved in ovarian cancer. I've never seen as much money or awareness. It's pretty amazing. And I think this is the most exciting time in the field that we've seen in decades. And we're starting to make progress in all the things we've talked about, right? Early detection and prevention and therapy. I mean, like we literally have new drugs now for patients with BRCA mutations, for patients who get ovarian cancers. We're really evolving our ideas about early detection and prevention in ways that, you know, in 2000, we had no clue where this was going to go. So I think it's a very exciting time, and it's been kind of going up on this sort of exponential growth curve. And I also give a lot of credit to organizations like Overcome, because it's a lot of the grassroots efforts in terms of the education and awareness that leads to more funding, that leads to progress, comes from that. And so I think it's a very exciting time. And I'm looking forward to, you know, in the next 5-10 years, you know, even making more progress so that we give patients better opportunities, better choices, better treatments for this, you know, disease that has historically been, you know, a lethal disease.
Yeah, and we are proud to have you on our advisory board, so thank you so much for that. Great conversation. Thank you so much, Dr. Draken. And if we have any questions, we'll make sure to bring this back to you so you may address it for our overcomers.
Absolutely.
So thank you. And overcomers, thank you for watching. We will be back with our next Connect Over Copy very soon. So till then, bye.